Hello, this is Dr. Marty Lustig, Principal with NextGen Advisors. Welcome to our podcast series featuring senior leaders from NextGen Advisors team. I'm joined again today by my partners, Graham Brown and Dr. Betty Rabinowitz. Welcome, Graham and Betty.
Good morning, Marty. Nice to see you.
Hey, Marty. Good to be here.
This past September, we did a webinar on patient engagement that focused on how providers can build stronger connections with their patients using virtual visits, patient portals, and social media. In anticipation of a follow-up webinar on January 27th, today we're going to discuss the other critical aspect of patient engagement, the approaches used to help patients change their behaviors to improve their own health status. With so many of today's chronic health challenges driven by nutrition, physical activity, and stress, the need to effectively support behavior change is greater than ever. Betty, as you think about the patients you served, what themes come to mind in this regard?
Thanks, Marty. My sense is that it was one of the biggest challenges of clinical practice that I experienced, where I watched patients who had hugely negative consequences to their behaviors, patients who had diabetes, who weren't able to control their weight and diet, patients who drank alcohol to an excess and lost jobs and marriages and family relationships. And it really was the biggest challenge to get people to change behavior and sustain that change. I think I watched people change behavior for brief periods and then kind of go back to what they felt comfortable with and were used to. And it was extremely difficult to remain connected and engaged in spite of these disappointments.
Interesting. Graham, as a non-physician, can you share what you've experienced when it comes to motivating behavior change?
Sure, Marty. I'll answer this from my perspective in working with executives and their management teams, change initiatives, and how they, improve performance in other projects. So mastery, autonomy, and purpose are three pillars of self-determination theory put forward by Dietschy and Ryan. And that's a useful framework for, I think, how we understand why change can be hard to implement in the work environment, because that's where, unlike Betty and you, I have my background and expertise. When we think about, first of all, as Betty was noting, change is hard. It really challenges. If we use just an example, say in 2020, hundreds and hundreds of new providers started providing telehealth and virtual care. And that's kind of a fundamental way of doing business in a different manner, a clinical interaction in a different manner than they would have before. So if we think about that, provider sense of mastery of that patient engagement, that discussion, is really upended when we think about doing a task in a totally different way. So that sense of mastery that they have about how they work with their patients all of a sudden is challenged. In an organization, no matter how inclusive a change initiative might be who is at the table in designing it, ultimately there are going to be workers who weren't involved in designing what that change is going to look like. So again, to the virtual visit example, you might bring in a new platform and new technology. The folks don't have a sense of how this is going to impact their work, their sense of autonomy, their ability to decide how they do their work is now being imposed upon by some new tool or new process. So again, kind of another challenge to it. And then finally, if we think about how work gives us purpose and how interacting with a patient and the provider relationship is really key to motivating people to understanding what's going on. If we're using new tools and new approaches, that can potentially place a temporary barrier to what that relationship looks like. If the provider is focused on the tool and the technology instead of the patient, then how they incorporate that into their model of care is one of these big changes it takes a while to overcome. So I think there's a big hurdle to get over when we just think about how we implement this in practice redesign. And the virtual visit is probably a example that's fresh on people's minds from the past year on how change can be so difficult.
Interesting, a pretty enlightened view, I think. I'd like to go back a little bit because as I think about this whole issue, when I was in training, I remember being told that I should always recommend to my patients who smoked or abused alcohol that they should quit. And that was pretty much the extent of my behavior change training. The teaching point back then was that, you never knew if at some point a patient would take the advice to heart and make a change, and kind of left it there. Betty, I'd be curious if you can talk a little bit about how you see the science of supporting behavior change has changed through your career.
We're about the same vintage, Marty, so I as well was trained that patients need to be told to quit. Interestingly, when you look at the science of that, when patients are asked whether their providers, smokers, whether their providers recommended smoking cessation, the majority of patients reported that they were never recommended to stop smoking. Now, obviously, there's a question here whether the recommendation was made and forgotten or not registered, or whether many physicians, even though strongly believed that the patients needed to stop smoking, didn't engage in that conversation because they felt so powerless and so helpless to really have that recommendation meaningfully followed. Over the years, we have developed a much more better understanding of what works and what doesn't work. For example, we know that scaring patients, showing them pictures of destroyed lungs or cirrhotic livers or people in anguished situations, works. It might work for some patients, but for the majority of patients actually is very counterproductive. Patients disengage from the message, go into a mode that really switches off communication around it. So scaring patients isn't any longer the meaningful approach. I think in the webinar on the 27th, we will have this opportunity to have a national expert on motivation and self-determination theory, which is a construct that truly provides the practical scaffolding for a meaningful intervention to try and work with patients in ways that create change that ultimately is sustainable. It is difficult. Addictions are difficult. Behaviors are very tightly held by patients. We all know how difficult it is to change what we do.
Graham, you want to add anything to that?
Yeah, I agree with Betty. I think the research has shown that knowledge alone doesn't change behavior. Back to the smoking example, I remember I'm from Canada, as you guys know, and in Canada and many other countries, they changed the packaging on cigarettes to put a really big warning in big bold letters, smoking causes cancer. And then in Canada and other places, they started putting photos of damaged lungs or people with voice box tubes because they had had some dramatic surgery as a result of throat cancer or something. And, ultimately it showed, to Betty's point, that worked for a very small percentage of individuals. Many other people then, hid their cigarette pack, bought a leather case to go on the outside of their cigarette pack so they didn't have to look at the bad picture. And they could put it out of their mind. When, back to this motivational theory concept, when you've got many deeper needs that are being met by the addiction, the knowledge about their damage doesn't necessarily motivate you to change. You need to go deeper than that. And so, like Betty, I'm really looking forward to what Jeffrey Williams is going to be speaking about, because I think he can really help us unravel this a little bit better and get a really deeper understanding of what does work.
Great. One other side of this, we often see, particularly with employers and health plans, that offer direct financial incentives to folks for changing to more healthy behaviors. Betty, can you talk a little bit about what we've learned about that particular approach to behavior change?
So it's a fascinating area, and behavioral economics touches a lot on the power of incentives and the use of incentives. And obviously we know that in other industries or in commercial endeavors, incentives drive customer behavior to a great extent. So it's completely natural to believe that it should be the same in healthcare. And even though there are areas in research and science that still completely support use of incentives in healthcare as well. Differential payment on premiums, discounts for patients who are not smokers. Employers have been fascinated by this option quite a bit. If you adhere to motivational and self-determination theory, you understand the concept and the difference between internal motivation and external motivation. And one of the risks of external motivation is that when you remove the incentive, the behavior decays back to where it was before. So to the extent that you can create continuous incentives, and then it's not incentives, it's kind of something else, you can expect the behavior to continue, but that people will not be incorporating deep changes that allow them to sustain the change when the incentive is gone. I'm sure that there could be proponents of incentives in this area who would argue and show data that they have had successes. It'll be interesting to pose this question to Dr. Williams on the 27th.
Mm-hmm. You know, myself actually having dealt with this on the employer side a fair amount from my time at the health plan, one of the ways that employers think about these direct incentives is that even if they don't necessarily get people to change behaviors, they attract healthier people as employees because they essentially get a better benefit package if they have healthy behaviors than if they don't. So it's, you know, the unintended consequences in this case for the employers are good ones, but it also then discriminates against people who have health conditions in a not so subtle way.
That's very interesting.
So a little bit of a twist on this one. You know, you mentioned other industries using them. Graham, can you talk a little bit about how you think about how healthcare really compares to other industries in this whole area of behavior change?
Yeah, I think healthcare is really a unique business. And I'll take it from the perspective of innovation in healthcare. When you think about, a new diagnostic or a new treatment approach being discovered by a researcher, and they then publish their first paper, they present it to an audience, other clinicians review it, they start doing their own research, they validate that. Eventually in time, that practice or that approach may become the new common way to do clinical care. But it's really a long evolution to go from research table to practice in theory. And it can be, it's ramping up. It's coming faster now than it used to. We certainly saw that with the COVID-19 vaccines and the sharing of information there. But it's been a 10-year trajectory from research bench to practice. And I really can't think of any other industry that works that way. When we think about the audio industry, for example, if a car company develops a new innovation that's a safety protocol or an advanced feature, all of the other car companies try to adapt and adopt their platforms and their tools to grab that innovation and bring it into their own product. They don't want to cede market share to the innovator, and they want to be seen as just as advanced and just as capable. So I think that's very different when we think about healthcare, how healthcare is practiced, and the long window that it takes for change to come kind of at the practice level. Again, not being the clinician, I won't speak about how it applies directly to patients. Betty,
your thoughts?
I think that it was interesting when Graham spoke about healthcare as a business. It's an interesting, even to think of it for me in those terms, even though obviously I'm not naive to the fact that healthcare is a very large business. But I think that the changes that we expect patients to make are difficult, are challenging, and chronic conditions are associated with core challenges that are not like trying to convince a consumer to buy one brand of a television or a different brand of a television, or adopt one sneaker line versus another sneaker line, or create incentive programs for people to buy a new model of a car. I think these are truly deep, painful, challenging behaviors that are so complex that there's only so much we can deduce from consumerism, for-profit business, and these very complex relationships in healthcare between providers and patients and their families, patients and their diseases. I think it's a unique reality.
Yeah, it seems to me one of the big differentiators is the time frame issue. Most of the time in healthcare, we're asking people to actually sacrifice things that are giving them short-term that are hitting their pleasure center, in order to avoid long-term negative consequences. So there's never any real internal positive reinforcement for the behavior change. It's mostly, give up something that I'm getting a lot of satisfaction from right now in order to get something in the future that isn't entirely clear to me what I'm getting. And it's hard to think of other industries that have that steep of a hill to climb in trying to motivate folks.
Yeah.
Marty, to that point, I think, with smoking versus drinking are interesting examples of vices here, where smoking, you may have a bit of a cough, but you develop cancer in 20 years. Drinking, you may stumble down the stairs and break your neck that night. You may get into a fight. The consequences with some of these behaviors can be much more rapidly experienced. And so, at the same time, the pleasure that you're describing that comes from what's driving folks to drink or driving folks to smoke, at the end of the day, is still a need that needs to be satisfied, needs to be recognized and either replaced with something else that's positive, or be put at bay in recognition of that longer term outcome that's a benefit. And that's a hard thing to get your head around.
And I think when you start mixing in addiction and our understanding of the chemistry of addiction, and it becomes, I have worked with patients struggling to quit both smoking and drinking, who by the time they quit or were forced to quit or were motivated to quit, hated the habit so badly and understood its destructive force over them, but were in the grips of a terrible addiction. I think that, for example, adopting exercise, which is neutral in terms of it's a bit different than an addiction like smoking or eating or drinking. There's a behavior which is burdensome to some. Some people enjoy it tremendously. For me, the best time after exercising is when I've done it. I do it because I have to. I'm not one of these, I don't know what people are talking about, these clouds of endorphins. I take their word for it, but for me it's the satisfaction of knowing that I did what I needed to do. So there is a change where there isn't particular pleasure. It's just a commitment that you make to make an investment. It's really about investment. That's another interesting thing to motivate.
Well, thank you. I think I'll let that be the last word, Betty. As mentioned at the start of the podcast, and actually a couple of times during the discussion, on January 27th at 2 p.m. Eastern, we'll be hosting a webinar on today's topic with our very special guest, Dr. Jeffrey Williams. Dr. Williams is a physician and health psychologist who has contributed greatly to the development of the self-determination theory model, and he has extensive experience in its application into clinical practice. I'm sure you'll find this webinar both stimulating and of enormous practical value. To register, you can go to the events page of nextgen.com or click on the link in our blog for today's podcast. Thank you for joining us today. I'd like to thank my colleagues, Dr. Betty Rabinowitz and Graham Brown, for sharing their insights. As always, if you enjoyed the topic today, you can consider subscribing to our podcast. This is Dr. Marty Lustig with NextGen Healthcare, and have a great day.